Good morning, everyone. The topic for my seminar is rTMS in neuropsychiatry. Transmagnetic stimulation is a non-invasive and comparatively painless research technology that has therapeutic potential in a variety of mental and neurological conditions. This is the trolley, which has the cooling unit, and this has the magnetic stimulator. This is the coil, which is used to give the electric current. This is the chair and the pillow, which helps to make the patient's head comfortable. This is a cap, which helps in marking of the brain marking of the patient. In the first session, we mark the area which we are targeting, and which this cap can be used for the next sessions. The basic principle of transmagnetic stimulation is based on Faraday's electromagnetic induction. Faraday made the electromagnetic induction discovery, according to which electric energy around the primary coil could be converted to the magnetic field and vice versa. This is the basic principle which rTMS follows, in which from the coil an electric pulse is used to generate a rapidly changing magnetic field around the scalp. And when the magnetic field crosses the scalp, it induces an electric current, which causes depolarization of the neuron. So the primary current is the metal coil, and the secondary current is from the body tissue itself. The mechanism of action: the immediate effect is within seconds. TMS produce immediate effect like quick jerk movements or inhibition of other TMS pulses. This results in direct excitation of excitatory and inhibitory neurons. Intermediate effect is seconds to several minutes. This probably arises from the transient change in local neurotransmitters. Long-term effect over days to weeks. This is reflected by behavioral changes and decreased activity of the hypothalamus pituitary adrenal axis, suggesting a regional change in neurotransmitter release, transsynaptic efficiencies, signaling pathway and gene transcription. This diagram shows different transmagnetic stimulation pulses. This is a single pulse in which a single magnetic field pulse is given. This is a paired pulse TMS. In this modality, a sub-threshold and a supra-threshold stimulus are paired together. Coming towards repetitive transmagnetic stimulation, it has two types of pulses: low frequency, that is less than 1 Hz, and high frequency, more than 5 Hz. Low frequency TMS, also called as slow rTMS. Here the brain area is stimulated with less than 1 Hz frequency. It is applied for longer duration, ranging from around 10 to 15 minutes. This induces a long-lasting inhibition of neural excitability known as long-term depression. Therefore, it causes decreased cortical excitability. High frequency, more than 5 Hz, also called as fast rTMS. In this, stimulation occurs for a short period at a higher frequency. This causes long-term potential and persistent rise in neuronal excitability. Therefore, it increases the cortical excitability. Planning for rTMS: we screen for the contraindications, we determine the area of stimulation, we localize the area of target, we decide the type of coil to be used, and we set the stimulation parameters. The absolute contraindication is a metallic hardware in close vicinity to the coil, that is cochlear implant, internal pulse generator, medicational pumps. Relative contraindication is high risk of seizure, history of epilepsy, CNS lesion, alcohol withdrawal state, drug lowering seizure thresholds, and sleep deprivation. Uncertain risk is an implanted brain electrode, pregnancy, severe and recent heart disease. Area of stimulation is decided through theoretical rationale and evidence. Localization of target is done through anatomical landmarks and neuronavigation. Anatomical landmarks is usually done using the 10:20 EEG system. It can be done without additional apparatus, but it is less accurate. The neuronavigation is done usually MRI guided. It is structural functional imaging. It needs separate and expensive apparatus, but it is more accurate. This is the EEG 10:20 system. The FP1 denotes the orbitofrontal cortex. F3 denotes the dorsolateral prefrontal cortex. The area in front of the CZ, that is the vertex of the head, denote the supplementary motor area. The type of the coil: figure of 8 coil is most commonly used. It is used in focal rTMS. It allows a detailed cortical mapping. The maximum stimulate is at the junction, that is at the center of the coil. Double cone coil and H coil are used for deep stimulation. Double cone coil is up to 4 centimeters, and H coil is used for deeper focus stimulation. Motor threshold: A single magnetic pulse, when applied to the motor cortex, generates a visible twitch in a particular targeted muscle, that is usually the abductor pollicis brevis, which is associated with a compound muscle action potential called the motor evoked potential. The motor threshold is the lowest intensity required to elicit MEP of more than 50 millivolt peak to peak amplitude in at least 50% of the successive trials. Motor threshold can be assessed by visual determination or MEP recording. Motor threshold basically is the standard which determines the dose of rTMS we have to use. How do we determine the motor threshold? Is we see this is thanks to courtesy of Dr. Pal. We mark the CZ, that is the vertex of the head, by calculating the area between the nasal and the anine, and then we take 5 centimeter towards the left from the tragus, and we mark that area, and we stimulate it with the coil until we reach that only out of 10 stimulus, only 5 are showing a twitch in the muscle. That is the motor threshold. So we'll take 5 centimeter towards the tragus. And then we'll stimulate this area with the coil, waiting for around 5 twitches out of 10. The motor threshold varies from individual to individual, but remain relatively stable over time for a particular individual. Frequency is the number of pulses per second. Train is a continuous set of pulses at a specific frequency. Intra-train interval is period of no stimulation between two trains. Repetitive TMS. rTMS applies a series of pulses to a specific region of brain at a certain intensity ranging from 1 to 20 stimulus per second or greater. This induces inhibition or fascination, which depends on the frequency of the stimulation. Theta burst stimulation. In this modality, a specific area of brain is repetitively stimulated by short pauses of rTMS at a higher frequency with breaks in the middle. These are short bursts of 50 Hz of rTMS. This is continuous type and intermediate type. These are short sessions and more robust plasticity is seen. This is the conventional rTMS, in which we see excitatory and inhibitory. Inhibitory, as described earlier, is low frequency, that is less than 1 Hz, and high frequency is 10 Hz. So it is excitable, is high frequency. Theta burst stimulation consists of continuous theta burst stimulation. In this, we see a 50 Hz triplet burst repeated at 5 Hz as an uninterrupted train for 40 seconds. While in intermediate, there is a 2 seconds on period and 8 seconds off period. So the continuous theta burst stimulation reduces the cortical excitability, and intermediate theta burst stimulation increases the cortical excitability. So intermediate is excitatory and continuous is inhibitory. Evidence in psychiatric disorder. The commonly studied psychiatric disorders are depressive disorder, schizophrenia. We have targeted auditory hallucination and negative symptoms. Obsessive compulsive disorder, PTSD, panic disorder, substance use disorder, generalized anxiety disorder, neurodevelopment disorder. Out of these, depressive disorder and OCD is FDA approved. Coming to depressive disorder, two different approaches for the treatment of major depressive disorder have emerged. That is high frequency rTMS of the left DLPFC. High frequency causes rise in the neuronal excitability. So it is aimed at correcting the alleged hypoactivity in the left DLPFC, which we find in depression. Low frequency rTMS of the right DLPFC, which is aimed at reducing the alleged hyperactivity. A meta-analysis showed that increasing the number of sessions and the total number of pulses per session with an optimal value of around 1200 to 1500 pulses per session was associated with the increased antidepressant efficiency of high frequency rTMS of the left DLPFC. and and to uh, and to replace high frequency rTMS by intermediate theta burst stimulation. Intermediate theta burst stimulation is causing increase in the cortical excitability, so it will take care of the hypoactivity of the left DLPFC, which we see in depression. So we are trying to replace the high frequency rTMS by intermediate theta burst stimulation. On August 14, 2018, several companies have received FDA clearance to include ITPS of the left DLPFC. A meta-analysis compared the odds of response of various rTMS forms and stated high frequency rTMS over the left DLPFC is superior, followed by low frequency rTMS over the right DLPFC. In bipolar depression, only higher frequency rTMS over the left DLPFC have shown to cause significant effect. Same is seen in refractory depression as well, that higher frequency rTMS is added to the antidepressant treatment has found to be usually safe, well tolerated, and useful. There is strong evidence for significant positive effect for the use of rTMS for treating in post-stroke depression, both immediate as well in long-term effect. In a recent study of efficacy of rTMS in post-stroke depression, it was found that 10 sessions of active rTMS of the left DLPFC was associated with a significant reduction of depressive symptoms. The reduction of depressive symptoms was not influenced by the patient's age or the type of coil we were using, or even the distance of the coil, or even the type of stroke. But there was a positive correlation between the reduction of the Hamdy score and the frontal gray and white matter volume. A meta-analysis of 10 RCTs showed that rTMS significantly reduced the suicidal ideation and severity of depressive symptoms in the patient. A meta-analysis compared ECT versus rTMS in 9 studies. In the response rate, ECT was seen to be more effective. However, cognitive adverse effects were increased with ECT. There was no significant difference in the discontinuation rate. The subgroup analysis shows that ECT was more effective in psychotic depression, while ECT and rTMS were equally effective in non-psychotic depression. The protocol used in FDA-approved study for depression is 10 Hz in 4-second strains, followed by 20-second intra-train rest interval at 120% of the motor threshold, that is around 3,000 pulses per session. Coming towards mania. In patients with mania, unlike what is observed in depression, there is a relatively increase in metabolism on the left side and lower anterior metabolism on the right side. Saba and colleague gave TMS at frequency of 10 Hz to patients with mania over the right DLPFC, and the patient displayed an improvement assessed by the mania assessment scale. A trial randomly allocated patients to receive 10 sessions of high frequency rTMS over the right DLPFC, and there was seen a reduction in Weimar scale of mania. What I did in my thesis is that I gave continuous theta burst stimulation to the left side. That is, I inhibited the hyperactivity. Schizophrenia is a multidimensional construct. Each dimension may be associated with a different pathophysiology. Different targets used for rTMS are auditory hallucinations and negative symptoms. The first successful report was by Hoffman and colleague that transmagnetic stimulation of the left temporoparietal cortex in 3 patients reporting hallucinatory voices. This showed a positive report in these 3 patients. People with auditory hallucinations have deficit in speech perception compared to the normal group and patients without auditory hallucination. Left temporoparietal cortex is involved in speech perception. So we target this area in TMS, that is the T3. Meta-analysis of RCTs, low frequency rTMS over the left temporoparietal junction showed the effect size of 0.4 to 0.63, indicating its superiority. Hoffman and colleague in 2013 stated involvement of the right temporoparietal cortex in the genesis of auditory verbal hallucination. A study conducted by Skergil and colleagues mapping auditory verbal hallucination in schizophrenia using functional MRI suggested that AVH was associated with bilateral temporal cortex. Hence, we have summed that bilateral rTMS would be superior to unilateral rTMS. Vilvinia and colleague delivered continuous theta burst stimulation over the both temporoparietal cortex for 15 sessions in a small series of 16 patients and found a beneficial effect of real versus sham continuous theta burst protocol. So the question is, are different TMS like theta burst stimulation more promising for treatment of auditory verbal hallucination or not? rTMS for negative symptoms, the site we targeted is fast rTMS over the left DLPFC. A circular coil was used to study delivering an inhibitory theta burst, intermediate theta burst stimulation protocol over the left DLPFC in a group of 24 patients. This was found to be efficacious than the high frequency. In a sham control study, a totally different rTMS protocol was proposed that the ventral part of the cerebellum was stimulated at 5 to 7 Hz frequency in 600 pulses in one session. The negative syndrome subscore of the PAN-S is significantly improved. Coming towards OCD, imaging data implicates an overactivity of the prefrontal basal ganglia circuits in the pathophysiology of OCD. High frequency bilateral DLPFC and low frequency DLPFC stimulation have reported the most global improvement. Low frequency rTMS of the pre-supplementary motor area. A meta-analysis of Reen and colleagues found that low frequency rTMS of the pre-supplementary motor area yielded a greater reduction relative to other cortical targets. However, taking into account the conflicting results, no recommendation can be made. The site of stimulation is a point situated 15% of the distance between the ion and nasion, anterior to the CZ on the sagittal midline. Low frequency rTMS of the orbitofrontal and prefrontal region. Two independent sham control studies showed the superiority of low frequency rTMS of the right DLPFC when compared to high frequency or sham to improve the OC symptom, which was assessed by Y-box. High frequency rTMS of the prefrontal region. FDA approved the use of deep rTMS as an adjunct for treatment of adult patients suffering from OCT on August 16, 2018. That is non-focal high frequency rTMS for bilateral stimulation of PFC anterior cingulate cortex region combined with individualized system provocation. Coming to a substance dependence, cocaine craving, a study by Campbell found that only one session of high frequency rTMS over the right DLPFC transiently reduced craving in cocaine dependent individuals. DLPFC stimulation can induce subcortical dopamine release in caudate nucleus, which may be the possible mechanism for reduction of craving. In alcohol craving, the beneficial effect was seen by low frequency rTMS of the right DLPFC. In nicotine craving, beneficial effect was seen after high frequency rTMS to the left DLPFC. In anxiety disorder, neuronavigation was used to stimulate the right DLPFC, which showed reduction in Hamilton Anxiety Rating Scale. In post-traumatic stress disorder, high frequency rTMS and low frequency rTMS targeted at the right DLPFC showed significant improvement. A protocol of high frequency rTMS in patients with PTSD after brief exposure to a script of traumatic event within the same session for 12 sessions over 4 weeks. In this study, a bihemispheric medial prefrontal cortex area was stimulated rather than the right DLPFC. This also showed a significant effect. Coming towards the summary, in depression, the recommended parameter is high frequency rTMS targeted at the left DLPFC. In bipolar depression, also it's the same high frequency rTMS targeted at the left DLPFC, same for treatment resistant and post-stroke. In auditory hallucinations in schizophrenia, low frequency rTMS targeted at the left temporoparietal cortex. In the negative symptoms, high frequency rTMS targeted at the left DLPFC. In nicotine use disorder, high frequency rTMS targeted at the left DLPFC. In obsessive compulsive disorder, low frequency rTMS targeted at the right DLPFC. In general anxiety disorder, low frequency rTMS targeted at the right DLPFC. In post-traumatic stress disorder, high frequency rTMS targeted at the right DLPFC. In Indian scenario, this technique requires an elaborate and expensive setup, which is difficult in a low social economic status country. In our country, there's a lack of awareness of the potential that this technology holds in the patients. The recruitment of patient is also difficult since repetitive session of rTMS may mean a loss of work for the patients, which is an important factor. Despite that, India has been able to produce one of the maximum numbers of research papers on this subject. Some of the research papers in India are seen in severe depression, in schizophrenia, in bipolar mania, in OCD, in bipolar depression, and in schizophrenia targeting the negative side.
Any questions, comments, clarifications? Dr. Vishnu. I think many of you are working in this area. Clarification.
Basically, rTMS follows Faraday's electromagnetic induction. That is, according to which electric energy around the primary coil can be converted to magnetic field and vice versa. So when we give an electric stimulation around the scalp, a magnetic field is formed. What the magnetic field does is it crosses the scalp and induces an electric current. So we have two circuits. That is, the primary circuit is the metal coil, which we give the electric current, and the secondary circuit is the scalp itself, which is being induced by the magnetic field around it, but it is giving the electric current to the neuron. So it is causing the changes in the neuron.
It is basically electrical stimulation. The electrical stimulation is induced by magnetic stimulation. Electrical field produces magnetic field, which we can produce secondary electrical field. So that is that. Any video? Or you need some information? Can you tell what is the difference between this and like ECT or direct stimulation? Or is that how is rTMS superior, or you can say better? Direct stimulation.
rTMS is better because we do not need to give the patient anesthesia, and we are not inducing a seizure in the patient. And as well as there's no cognitive impairment associated with rTMS. It does not.
It's like ECT based magnetic stimulation to produce electric, like rTMS produces lesser electric stimulation. When produces stronger stimulation, seizure, and that is equivalent to ECT. Okay. So what is the novelty in magnetic? First is the impedance.
The skull is not giving equal resistance.
ECT, the variability in dosage in different patients is because of the impedance, that the skull and the breadth of the skull, hair, etc. So 70% of your electrical energy is maybe absorbed by skull, and the 30% goes to the brain and it produces the effect. Okay, but the thing is that we don't know in which individual how much impedance will be produced. So it can be variable. Age is a factor, different things are factors. So that is why this extra electrical solution that we have to use produces a variable effect. Number two, if you have to directly stimulate some deeper thing, so you have to directly, there are methods by which you place an electron inside the brain. Okay, and then you stimulate, that is invasive. So here there are two things. One, impedance is not affected. So magnetic field, it actually is sitting inside the brain without the impedance. So it is more predictive. You have done yourself.
Yes.
And you have given ECTs also. There is not much change in the stimulation that you require in different patients. Secondly, you can stimulate deeper structures directly without accessing. That way it is.
Good. Is TMS, does it takes into account inter-individual variables?
Yes, sir. Sir, we are calculating the motor threshold for every different patient, and we are stimulating according to
RT, CT, or TDCA.
We follow one protocol.
Like magnetic PLX, ST. We don't do it. So that is what one advantage it has. they're actually taking into some account for inter-individual.
Appears naive, it is not that naive. It is actually electrostimulation. You can see the muscles are moving and two patients you had seizures. So it is
and focality of stimulation, which is not replicated by ECT.
So, but
It is generalized stimulation.
that there's a study that was coming up that transmagnetic stimulation can be used in seizure as
Yes. So any epileptic foci, you limit that area by regulating protocols. For that, you need to localize. Any area which gets more excitable,
can be
that you
inhibited.
can see. One of the patients with depression, we were giving 20 hertz left DLPFC, but he was still smoking 20 cigarettes per day. What is your take on it? They showed that it helps in nicotine. Huh?
Yes, sir, that it helps in nicotine craving.
How you explain it? So you continuously 20 sessions he had, didn't show any improvement in nicotine cessation.
Again, if you go to that list of areas, most of the indications are for the DLPFC.
Yes.
So then how do you say it is specific? Disorder you are doing the
Because in a number of studies, that is the main target which has been used. There are other studies which have used different targets, but there is more studies done on this area only. So because new studies are coming up for pan theta burst stimulation or continuous.
The areas may also be effective, but I think one of our thesis is like GAD, like there are some other studies, so we are doing it in a different area.
And also, if comorbidities are present and then both the comorbidity same site is involved, then we can use RTMS, the therapeutic option. But problem will be there are different sites involved or different paradigms involved, different kind of neurofunctioning. Then you won't be. Any other questions?
No, it is written that it is relatively unsafe. That is, well, there are no studies, so it is just given as relatively unsafe.
But it is electrical stimulation. Don't play around with it. वहाँ पे घुस के जिससे दोनों करने लगे।
और patient को मिली
Yes, sir, ma'am, it is written as a contraindication that any metallic instrument or anything metallic near the area where stimulating should not be present. So it is
Anything head and neck, anything head and neck, like similar to MRI. Below head and neck. Anything head and neck. All head and neck contraindications which are applicable to MRI are applicable to, because it is 1.5 Tesla of magnetic field. So but many a times they're saying it should be actually 10 centimeters gap of the head, then they can still give it, like in some implants they're giving it, but then that becomes risky in our context. Something happens, then we can be in these problems.
There are two things. The electrical current can affect any electrical place with it, but it is far away. Number two is that if a rod is there, so it is more of a MRI में इतना ज़्यादा होता है कि वो सब कर लेगा. So, but here it's so mild it is not producing mechanical, it is not producing.
Basically, around 60 centimeters distance, the magnetic variations are zero almost, so or equivalent to gravity. So then it will not make a difference. So if we go below spinal, something is there, it doesn't make much difference. That is why it is very safe in pregnancy. Fetal exposure is very, very less. Any questions? Yes.
Location that will be
Migraine. oxygen.
Thank you. The same media file. There was seen that there was a reduction in the intensity of symptoms through communication, as well as 4 weeks after, till 4 weeks after the session. Also, there was improvement in quality of life for the next 8 till 8 weeks. And sir, in chronic pain syndrome, apart from this, the person given cerebellum has also improvement.
I think
This is one indication. Chronic fatigue or
we
somatoform.
just want to do somatoform while at least he's doing two stimulation, one in PHC, one in motor area. And that is simultaneous, sequential.
It was very interesting. I'm very proud to see those studies and हमारे लिए problem reference it's very good to see research on this.
From Indian scenario, these are only few studies. I think we just had published a review. There are 30 studies. I think we have around 8 or 9 of them.
Yes, sir. In the article, they had mentioned that one group has done different studies in different areas.
Presentation of for example, the last table we had, I think table is the takeaway point of this lecture. And the concept is on the side.
So I think the presentation was good. You worked hard, but you could have been because you're thinking of, you're preparing it. If it like it would be a chapter in a book. Okay. It should be at least from PV3 or where we can send it for publication. And I think you can improve on it. Most of the data is there. So I think that slightly, if you improve it, then we can send it for publication. I think because more of a chapter like I would suggest, because here what it appears like in different slides you have described. No? So your handout is a accessory to your presentation. What I would want is a chapter, and then you make or a write up, and then you make a presentation from that. So the write up stands out. Okay, so for example, in the initially you describe what you're going to, core principles you describe in it, things like that.
Yes.
You can easily assimilate this information in a form that can make a chapter of it or can send it to publication. That's the purpose of handout, because if you like it's good. I'm not saying it is not. Your presentation is good, and your handout is an accessory to the presentation.
I actually agree that presentation is very good, actually, but 3 months handout, you ask yourself whether I have done justice to this handout, because this was started with seniors just because we wanted to introduce this activity with more finesse, and this was part of your subsequent evaluation in the exams. That is why we put that line. But if you put a handout 1 day before, what feedback we give? The point is, there has to be an introduction section. Initially, the summary of what you will put up, the individual headlines, the letter which we had furnished. There were guidelines on the font size. Tables fonts will be same. Your table fonts are different. And you were saying adaptations. So what adaptations you have done to the table? If you have adapted some table from some reference, what adaptations is there? What is your adaptation to it? That needs to mention. Summary is your adaptation, but I think our table before this is taken from somewhere. But what is the reference here? So these things are supposed to be, and when you plan and handout, you have to meet your guide coordinator for the topics, for the headings. Subsequently, you have to be in touch with the person, and it has to. It's not like any other seminar which you are doing. This is because this will then so that it can go to the publication. And previous two handouts also, I was talking about Meta also, they need also improvement. So I wish all 3 handouts we review rewrite, submit, and the date and the fonts, everything. See, you might feel little disappointed at this point of time, but we get when you go out from here, this exercise will help you. Because 3-4 write-ups before coming out of doing an MD will help you in subsequent publishing or writing or reviewing or critically helping someone. Because this is very, very important. And this is because 3 months you got the time, you could have possibly worked hard on the handout. That is why when you came to me, I said, not much time is left. You need to be, because most of the things are from the thesis only. So the more it needs at least 4-5 editions. It needs, when you look at it, it needs to be more crisp, and the message should be should have been more better. Presentation wise, I think you people have improved a lot. There is not much to say, but I think this needs a lot of hard work. But I don't think so. Now you have much time. You've already exhausted your opportunities.
Like
Or you want
students have published chapters. So you can we can send it for publication as a chapter to a book.
Who put the next handout? Who is the next handout? But I usually would request whomsoever is the moderator. You actually sit with the moderator, decide on the headlines. Then one section, keep on editing it. References at the last. And like as sir said, then when you finish your handout, then make a presentation out. So that when it is it comes out, it is a final product. But if you want help, that is why we have put our name also among the chairperson coordinator. Anyone basically you can come in, because that is very important part of the exercise. You might get 3 or 4 handouts till you finish your handout. Actually, that experience will help you a lot. Subsequent. Thank you.
Oral presentation is one thing.
Next
Written presentation is one thing. You'll be publishing articles. After that, CSR.
This exercise will help you out because headlines, subheadings, all these things needs to be edited. Because you can see itna bada headline is somewhere underlines and not. When you read a chapter, you will see the flow of the chapter, the fonts, the sub fonts, then how they are using it, how they are making a paragraph first line and last line, why they are important, when to change a paragraph. So all these things are important. But when you work with your guides, co-guides, moderators closely, then actually you will learn all this. But 3 दिन पहले अगर handout मिलेगा तो क्या करेंगे? You can't put you into pressure also.
That is the main. Or whoever, like it is a different exercise I want to be doing. It's a different exercise from the regular CSR. So that the main purpose is that when you go out of here, you are able to make written document on any topic. Like here also we are doing like the NABH film book cover से बनाना पड़ता है, कोई this is also part of the work in the future. Okay, so that's how we are going to get a document. That is the main. The preparation of document is the main of this exercise. And the presentation is that you present that document. Now, journal club में करते हैं, you present the then you present that. The presentation was fine. The information here is adequate. You just need to refine it.
Yes.
The information here is adequate. It just needs to be put in the form of a simple you can say right. So do it after that.
And now IPS is looking for new talent, new people who are coming out for writing chapters, they are publishing books. You will get an opportunity, but if you not know how to write and where you will learn. After going from here, you'll become a consultant on SR, then you'll not say that, hey, let us have opportunity to learn. Nobody will tell you. This thing will never happen anywhere.
Souvenir also.
Yes.
But you see the quality, you can see the difference. And you can do it. That's why we are telling you.
Yes.
Very easily.
Thank you.